One.
Thank you very much. Good afternoon, everyone, and I'd like to welcome the faculty. First of all, I'd like to invite Jenny from OrbusNeich to welcome us to this session organized by OrbusNeich, which looks at broadening the horizon in calcification and treatment. I'm Dr. Azhari Rosman. I'm from the National Heart Institute. With that, can I just pass over to Jenny, who is from OrbusNeich, to give us a few opening statements?
Yes, thank you, Dr. Azhari. My name is Jenny. I'm the Director of Training and Clinical Marketing. And on behalf of OrbusNeich, I want to welcome you and thank you for taking time to join us. And we are very privileged to have Dr. Azhari to be our chairperson. And also we have distinguished presenters and moderators with us. And I let Dr. Azhari to introduce them. Dato', pass to you.
Thank you very much, Jenny. Now, this is 1 hour 45-minute session. We're honored to have all the distinguished speakers who will be sharing their case experiences on today's sessions. Each presenter will have about 20 minutes with the question time at the end. So I request that you mute your telephones, please, and of handphones, and then mute your microphones unless you're actually presenting. So with that, I'd like to make a few introductory slides on this issue that we're going to discuss this afternoon, which is about the orbital atherectomy device. So this is about broadening the horizon in calcification treatment. As you know, let's have a look at the slides first. Let's put up slideshow. Yeah. 1 minute, Kamaraj. Let me just.
Yeah, no problem.
Okay, so this is about calcified lesions, which we are seeing more and more of, and one of the reasons is because we are going to see more and more of these. 1 minute, this slides gets stuck a little bit. Give me a short while. Sometimes this happens, lah. Okay, is it moving now? Next one, next slide. Okay, so sometimes this happens with various conditions. As you know, renal failure is one of the notorious ones, for example, yeah. And of course, patients who are older, advanced age, for example, previous hypertension and so on, especially diabetes. And the combination of any of these can cause a lot of calcified lesions. We also see more of this in younger patients. So it begs the question, how do we approach some of these lesions? And of course, we have various devices in the past, such as cutting balloons or scoring balloons, as they're called now. And then we've got the orbital atherectomy devices. We've got the rotational atherectomy devices and various types of it. So now this device was actually introduced back in January 2019, and I actually put in the MDA for this device. And since then, we've actually done 340 cases since 2019, which is quite impressive over the period of time, given the 3 months of COVID. And the next slide. So with that, we'd like to invite some of the experiences some of our presenters have got in regards to this device. And I'm sure many of you will see that you have questions on this relatively new approach to handling calcified lesions. So with that, I'd like to invite our first speaker, which is Dr. Kamaraj. He's the head of the interventional cardiology services in the Serdang Hospital, and he'll be talking about algorithms in treating calcified lesions. So, Kamaraj, I'll hand over the control over to you.
Okay. So before we start off, thank you very much for having me here. My name is Dr. Kamaraj from Hospital Serdang. I'll be talking to you all about algorithms in treating calcified lesions. Okay, as you know, I don't know, as an Australian guy told me almost 6 years ago or 7 years ago when I started off intervention, that calcium was the work of the devil. I think all of us who are involved in intervention really start to believe that as time goes by. We've got types of lesions. We've got the soft and fatty lesions, which we just need a semi-compliant balloon or an NC balloon to create a channel. But then we also have lesions that are fibrotic with mild to moderate calcification and severely calcified diseases, severely calcified lesion. So in the fibrotic or the mild to moderate lesions, we have got equipment that we can use: the cutting balloon, the scoring balloons, shockwave, and laser. However, for the severely calcified lesions, we need to remove the calcium, and atherectomy devices are the way to go. So we've got two atherectomy devices that we commonly use. It is the rotational atherectomy, and the Diamondback. So I'll go straight to my case. So this is a 62-year-old Chinese male, smoker, family history of heart problem, presented with central chest pain, 6 months history. ECG showed ST depression, V2 to V5, and impression was a non-STEMI. So we went in for an angiogram for this patient. As you can see, it was quite calcified, diffusely diseased, as well as it was a subtotal LAD. This is RCA, small. So we decided to, small and diffusely diseased, so we decided to intervene with the LAD first and then stage the RCA. So crossing this lesion was not easy. It's angulated and calcified, and went in first with the normal Renato wire, but it was not able to cross. I had to chain it over to the XTR, and after much manipulation, managed to cross the lesion. But crossing was just the first part of the story. As you can see, it was an extremely calcified, unyielding lesion. Managed to push in a SC2O and an NC25 at the tightest part of the lesion. But as you can see, the opening was suboptimal. So the tightest spot was not able to open, we couldn't open it and couldn't pass anything down that area after even multiple balloon inflations, and I decided that I needed a scoring balloon at least to be able to open up the lesion enough for us to do further intervention. So this is the tightest part there. Nothing was able to go down. As you can see, when you push in the balloon, the wire comes back. So I decided to use an anchor balloon technique, put in a Renato wire into the smaller branch and put in a 1.515, use it as an anchor, and managed to push down the Scoreflex NC 2.515. But I went up real high pressure, 22 atmospheres, to open up the lesion. Post-scoring angiogram, you can see some dissection there, but you can see quite obviously that the vessel has opened up. Managed to put in a distal stent 3024 and a proximal stent 3524. And this was the final angiogram. So this is a case of using a scoring balloon only to intervene in this type of calcified lesion. So why Scoreflex NC? I think most of us that have used scoring balloons have their own preferences. I prefer Scoreflex because it actually has the smallest crossing profile. So as what I previously stated is, I mean, a lot of them have got single wire, 2 wires, etc. Some can open at a higher, opens at a bigger amount or larger amount, etc. But I think, biggest problem is we are dealing with a calcified lesion. So if we cannot get the balloon down there, I think nothing else matters. So other than the crossing profile, it's also quite flexible. It's got very good deliverability. The other important thing about Scoreflex is that it is the only scoring balloon that uses an NC balloon. So it's an NC, as you know, it's got focus. It depends on focus force angioplasty. So it's able to open up the lesion in a it opens it up in a non-dog bone effect kind of manner. That means it's able to focus the force throughout the lesion, not concentrated in a particular point. It's just like cutting an egg with a fork and cutting an egg with a egg cutter. So the tension is evenly distributed, no dog bone effect, and it reduces the injury and future events. Whereas an SC, as you can see, has a dog bone effect, and we all know the more you push it, the higher chance of edge dissection and even perf can be seen in SC balloons. So that is all I have about the Scoreflex, and we will go on to the atherectomy devices actually that are present for severe calcification. The two we know, of course, rotablator, something I think most of us are quite used to. It's been around for 20 years. And the Diamondback, which has just come into our market, as Dr. Azhari said, in 2019. So a few things about rota. I think we are very comfortable using rota, and the concept of orbital atherectomy was quite new to most of us when we started it out. As you know, it's got, the rota is not changed actually in the past 20 years. It's got still a very heavy console. You need incredible eye, hand, and leg coordination in using the rota. And of course, for a lot of beginners, the sound of the rota burr is quite scary. Whereas orbital atherectomy is a more sleek device. It's got a pump, which is electricity driven. It's got a robust wire, the wiper wire. It's got a special lubricant called the wiper slide. Now, the important thing about this OAS is that the wiper slide fluid is something you need to be mindful of, because it is made with egg yolk and soy. So the first thing before you even use this product on a patient, you should ask for allergies to egg and nuts. Sorry, I'll show you this. This is the introducer. There's another picture which shows it a bit more clearly, but this is the knob, the start-off button, and these are the two speeds that are available, 80,000 and 120,000. So the first time I was introduced to it, I was a bit surprised, because it seems to be a one burr that fits all. Whereas, as you know, those of us who have used rota, we know that there are different sizes to the burr, 1.25, 1.5, 1.75 to 0. And but once you understand the mechanism of how the orbital atherectomy works, then maybe you get a better picture of why this is so. So I'll start off with a couple of cases that we have done in Sedang. This is a 61-year-old female, ACS unstable angina with hypertension and dyslipidemia. As you can see, it's a calcified vessel. It's diffusely diseased. And there is a distal, a distal kind of aneurysm. So this is the 1.25 crown. So for coronaries, we only use the 1.25 crown. And we did 2 runs. So the question often asked is like, how many runs do you do? How do you know it's enough? So the specialty about OAS, it actually doesn't depend on resistance, unlike rota. A lot of time it depends on the pitch of the burr moving through the calcium. So a high-pitched burr, high-pitched noise while the burr is moving through the calcium shows that there is a lot of calcium there. And a low-pitch sound shows that the calcium is either minimal or has already been cleared adequately. So this is a pre-OAS picture. This was the post-OAS picture. And this is after the PCI to the LED. As you can see, the lesion is well open and looks very good angiographically. So this is just a quick look at the OCT. Post-PCI, we didn't do it pre-PCI. This is just to show you how well the lesion has opened up and how good the stent opposition is to the vessel wall. Right, the second case is a 43 years old female, ACS anterior STEMI, hypertension, chronic smoker. And as you can see, the lesion was almost subtotal and with a big calcium chunk there. Here, sorry, use this. Right. So what I did with this lesion, we crossed the lesion, we crossed the wire, we crossed the wire, and then we put in a small 1.5 balloon and just went up nominal. Now, the reason is we are prepared. Whenever a tight lesion like this, you can always cause dissection. And the ultimate no-no in using an OAS is dissection. The reason is the OAS moves circumferentially, whereas the rota punctures a hole. So it is you're still able to get away using a rota in a dissection as long as it's not too bad. But in an OAS, if there is a dissection and you miss it and you use an OAS, what will happen is if the burr catches on to the dissection flap, you're going to get a horrendous outcome. You're going to get a horrible perf followed by a dissection all the way down. So luckily, there was not much dissection. There was no dissection, sorry. And we used again the 1.25 crown, LAD, first run, second run. So one thing is on angiogram, as you can realize, compared to the rota, the crown is not as visible, right? So what I would suggest with most of us that have got very bad eyesight, just magnify it 3 or 4 times. So this is the case. So this was the pre-OAS. This is after the 1.5 balloon. This is post-OAS, and this was the post-PCI to the LAD. As you can see, again, angiographically very nice. This is a case we did a couple of months ago. This is a hybrid case, rota OAS. It's a 63-year-old male, non-STEMI, diabetes, hypertension, CKD. And we did a stage PCI to LAD, and we only wanted to use rota first, but later it became a hybrid case where we needed to use rota and OAS. So this angiogram actually doesn't look that bad, all right? So that's why we decided to go with the rota first. So use the 1.5 burr. As you can see, it went in okay, quite smoothly. This is the post rota. But I put it in IVUS after rota because I don't know, I just felt I was not very comfortable with the opening of the vessel after the rota, right? After IVUS, we decided to do OAS. We did 3 low runs and 1 high run. I'll explain to you what the high run and low run is later. This is the picture post OAS. And this is the IVUS after the OAS. So this is the reason. Post rota, as you can see, at exactly the same point, the calcium was still 360. There was no breakage of the calcium, and we know that no stent is going to be able to expand in that. So still a 360 calcium. However, the second picture shows you what happens after OAS. As you can see, the calcium is cracked, and we were more comfortable and confident in trying to intervene in this lesion after that. So this is how the differences work, right? This is the rota, which, as you can see, basically punctures a hole, and the size of the hole is approximately the size of the burr itself. So about 1.5 hole, 2.0, etc. Whereas in OAS, what it does is it moves circumferentially and actually shaves off the calcium on the vessel wall. And hence the calcium removal is much better, especially for large vessels. So this is what I want to tell you. This is the introducer. So this is the advanced knob, which is basically got on and off black button. These are the two speeds available. There are only two speeds available, unless other than unlike LOTA, where you can keep on turning the knob to the speed you want. So it's either 80,000 or 120,000. So when you say a low run, it is at 80,000, and when you say it's a high run, it's at 120,000. Right? The 80,000 also doubles up as a dynaglide or glide assist kind of button. So you press that 80,000 until the light blinks and it goes down to dynaglide or glide assist, which works basically to take in or take out the burr during the procedure. Right? And the speed is very low. It's only 5,000 RPM. So, you know, it's not going to do any damage to the vessel or even the, you know, when you take it out by into the catheter. And how it works is simple. Higher speed, more centrifugal force, and more centrifugal force means bigger arc, and bigger arc means bigger shaving on the vessel wall. So that is how you get, you know, you can shave up a vessel of either from anywhere from 2.5 to 4.0 vessel using just a 1.25 burr. So pre-dilation we did with an NC balloon that still did not go too well. So that's why I said the calcium is a lot more than we had expected on angiographically. So I needed to use the Scoreflex as well. Post Scoreflex, it opened up reasonably well. Stented with a 3.0 mid LAD and a 4.0 proximal LAD, and post dilated with a 3.5 and a 4.0 balloon. And these were the final results. Right, this is just an IVUS picture to show you how well the stent has approached to the wall. Coming a bit more proximal here. Nice and circular. Well, with that, thank you. And thanks, OrbusNeich, for having me here today.
Thank you very much, Kamaraj. That was a very nice presentation, a very clear explanation of how the OAS actually works, and some background intro onto the hardware itself that you use. There was a question earlier on about the usage of a small channel opening balloon, and I think Rosli mentioned, about using a 2.0 balloon or 1.5 just to create a channel in case you cannot pass the OAS device. So Kamaraj, I have a question. The choice of the last case that you presented, in regards to the rotablation, why don't is there an option to use a bigger burr size for this gentleman? Do you think that would be a safe option, or do you want to move on to an OAS after that? Say cost issue, for example.
No. It's not actually. We were using radial, a 6 French sheet.
Right. Okay.
So if you were supposed to go up to a 1.75, we'll have to send it into a 7 French, or we'll have to go femoral. So our choice was whether to do the whole thing again, or just change it to an OAS where you can still use a 6 French sheet radially.
Right. Good. Okay. Thank you very much, Kamaraj, for that comment. Now, if you permit me, the next speaker to give us his topic will be Dr. Bala Kandasamy from IJN. He's a senior consultant cardiologist here, and he'll be talking, Bala, about application of imaging in calcified lesions. Thank you, Bala. So I'll give the screen to you.
Okay, thank you, Azhari. Thank you very much to everybody for inviting me to this webinar. I will be talking about application of imaging in calcified lesions. I'm Bala, I'm from IJN. Why is imaging so important? Actually, it's just precision PCI. Imaging is precision PCI where there's no guesswork. It takes the mystery out of angioplasty. What does this mean? It allows me to make efficient decisions for optimal treatment. And you must know what you're dealing with. So imaging helps us know what you're dealing with. You're either dealing with a fibrous lesion, a lipid-rich lesions, or calcified lesion. And these are the various findings in the OCT in these various pathologies. In image-guided precision PCI, it helps me optimize pre-treatment strategies. It will identify the lesion morphology. It helps me in the stent sizing, especially the vessel diameter and the lesion length, so that I don't land in the plaque and cause a plaque rupture. It also helps me in co-registration of precise placement of the stents. It helps me look at complete optimization treatment also, like edge dissection detection, optimal expansion, optimal apposition of the stent, and helps me, of course, minimize product usage. In this 11-center all-comers registry, where they did angiograms, they noted that there was 31% patients with calcification, and out of that, no calcification is 69% of patients. If you look at the intravascular imaging versus angiography, in a 1,155 target lesions, you get 76% of patients who contain calcium by IVUS. And out of that, only 26% out of the 1,155 contain calcium by angiography. So you can see the vast difference in identifying the morphology and the pathology of the lesion. Angiography underestimates calcium. As you can see in this angiogram, you don't notice any calcium. It's not visualized at all. And in the OCT, you can see from the 6 o'clock to the 2 o'clock position, there's extensive calcium, all right, with the MLA of 2.22, and the calcium is 5.16 in area B. In IVUS also, you can see calcium which is not visualized, and it is well visualized in the IVUS image. So calcification was visualized in 38% of coronary lesions via angiogram and 73% via IVUS. So we must see that we are missing quite a bit of morphology in if you're just doing plain angiogram rather than angiogram with imaging. The challenges to DS performance in calcific lesions, OCT IVUS helps us in preventing incomplete stent apposition, stent under expansion, and edge dissection. These are some of the problems we have in fibrocalcific lesions and calcified lesions which are not prepared well and which are not identified by imaging. So a defining success for calcified lesions, you have procedural success, which is just plain stent deployment, but you also must look at clinical success. Clinical success as stent deployment, expansion and apposition, leading to low TLR and restenosis. What are the options for treating calcification here? As Kamaraj has mentioned, you have atherectomy, which is between a rotational and orbital. Orbital moves forward and backward ablation with a dual mechanism of action. Rotational, which is only a forward ablation only. You have also balloons, NC balloons, OPN, cutting balloons, and now we have shockwave lithotripsy. Rotational atherectomy is unidirectional, front cutting. It's concentrically mounted burr which rotates to create a lumen same size as a burr. So you will see that the burr comes in various sizes, 1.25, 1.5, 1.75 and 2.0. And so one size doesn't fit all. So you must adjust your burr size according to the lumen diameter. And catheter use will be different also. 6 French and 7 French for the 175 and the 8 French for the 20 burr. Whereas you can see the images in a diamond-tipped burrs which spins concentrically on the wire. You will see the eccentricity of the bites given by the rotational atherectomy device, which is determined, which is guide wire bias. You can see in this lesion with the rotablator 1.5, it cuts eccentrically, and if you use a 2O burr, it cuts also eccentrically according to the guide wire bias. And after opening up with the Scoreflex, you can achieve some amount of well-opposed stents. Whereas in the orbital atherectomy, you have a 1.25 crown mounted and which moves concentrically. It is bidirectional, which differential standing and pulsatile forces. And as Kamaraj has shown earlier, this same slides, that the rotational movement slices off and debulks the calcium. And this one, you can see a rotational movement of a 1.25 crown in a 3 millimeter glass cylinder. All right, it is designed to treat 360 degrees of the vessel for improved compliance. It treats up to 4 mm. So a 1.25 crown can treat between 2.5 to 4 mm vessel. So that saves a lot of changing of slides of catheters. And in the eccentrically mounted diamond coated crown, it moves in a centrifugal force. If you see this IVUS image, the bites and cuts and ridges created are concentric. And after using the scoring balloon and subsequently the stent, well opposed, well deployed stent. You can see the effects of OAS in a concentric calcium. You can see circumferential bites given. The path given by the OAS is concentric. Even in concentric eccentric calcium, you get a good bite. Calcified nodules and fibrous calcific plaques. But you must be careful. That's why the advantage of doing OCT. In a soft plaque, you must be very careful because it will just create a bigger crater and bigger problems in a soft plaque. Let's go on to our cases which we have done in our unit. Case number 1 is a patient with an admission in November, chest pain since 4 months, shortness of breath, positive stress test at moderate workload. This is his pre-procedure angiogram. The area of interest is in the proximal LAD calcified lesion, extending from the before the first diagonal to after the second diagonal. The pre-OCT findings were, as you can see, from the distal segment, you can see calcium coming in, calcium here, right, in the U-shaped calcium distribution, horseshoe manner, and the lumen is quite tight. And as it goes proximally, it comes back to normal, about 3 mm in diameter in the proximal segment. This is the pre-procedure OCT at different levels. This is a normal proximal segment. In the mid segment, straddling the diagonal one, you will see a horseshoe-shaped calcium, which is very extensive actually. And as we go down, the lumen becomes smaller and concentric calcium is noted. So we had a first run of the OAS device at 80,000 revolutions, and this really opened up, as you can see, a lot of fissures and cracks and footpaths of the OAS device. You can see a lot of craters created. And next slide. This is the still pictures of the various segments of the cuts given. As you can see, it has really opened up segmentally in different segments. The calcium has been debulked. This helped us in our stent placement. And this is after the stent being deployed. As you can see, the stent is coming here, well placed, quite surprisingly well opposed and rounded, nice images of the stents. So OCT helps us really identify a well opposed, well deployed stent, and no cracks and fissures here. So this is quite a good case which we use for our imaging. And these are the final results in the angiogram, the cranial view and the caudal. Now, the second case, well, this title was given to me by Dr. Wan, Pursuit of Perfection. This patient was admitted on the 3rd of October, chest discomfort, calcium score 305, LED moderate to severe stenosis proximal and mid segment. ECG right bundle branch block. This is the pre-procedure angiogram. The area of interest is after the diagonal one branch in the mid segment, and you will see an aneurysmal, a small aneurysmal segment there. Okay, we proceeded with the OCT before trying to visualize what's happening to this lesion. You can see, surprisingly, as we come along to the mid segment, this is from the distal to the mid, the lumen gets smaller and there's concentric calcium, 360 degrees distribution of calcium, right? And as we go to the proximal segment, we open up quite well, but still some amount of calcium distributed there. See, this is in the proximal segment, stills, and here you can see the lumen is being compressed by calcium, concentric calcium. This is where the diagonal comes out, and here some more calcium. This is the first run. We used the OAS device with 80,000 revolutions per minute. We managed to open some extent, but even angiographically, you can see that it hasn't opened up really quite well. So we did an OCT post runs. We did about 4 to 5 runs actually on 80,000. As you can see, as we come along to this area, to the lesion of interest, there's a bit of swirl here. Calcium still present, not much of cuts and fissures created, very small amounts of cuts, not much ridges, and still calcium distributed concentrically. And this is near normal areas. So we decided to use a bigger chunk of debulking. So we went on to the 120. So this was at 80,000. You can see a lot of calcium here, still around here. Not much of debulking around here. That's about all. So we went at 120. Okay, 120 high speed. So this is a choice we made to improve the deployment of stent later on. So now we can see some more lesions being, as we come along to the lesion of interest, we can see the mapping of the OAS device with cuts and fissures. Yeah, look at that. Okay, nice ridges, fissures. It has debulked the lesion to some extent. That's where we are around here, okay, at 2 lesions. And for post-stent, we use, I think 3.5, I'm not sure, but this is after stenting the lesion. As you can see, the stent is coming in now. All right, the stent is coming in now. well deployed, well expanded stent. Okay, so this is a lesion which we converted from a 80,000 to 120,000, and this is the final results. Well, it looks pregnant, the stent. Good. So the results were quite good actually. We used a 3O times 23 at 18 atmospheres and post-dilated with 3.5. This is one nightmare of a patient. All right, 57-year-old male attempted PCI to LED with small balloons, sent from another center, but not successful and sent to us. And this is the angiogram, calcified lesions, but we can't appreciate anything more than a calcified narrowed stenosis in the proximal segment. Okay. And as we go into the OCT, we go into the proximal, towards the proximal segment. The area of interest is here. Yeah, you can see the calcium distribution and the very tight stenosis, and you can see a lot of cuts and fissures, craters in fact, and the bites are quite chunky. Okay. In the interest of time, I will move on to the next. And this is what was seen in the cross section at various levels. Very horrendous picture. 3 months after post-dilatation with the balloon, we decided, since the patient is not symptomatic, quite stable, we will restudy in 3 months' time. This is another rotablation case, another case which using rotablation and IVUS. Quite straightforward actually, this one, but we would just like to tell you about imaging can be done with OCT and IVUS. All right, the area of interest is the proximal segment straddling the septal 1 branch. OCT showing concentric calcium distribution. And as here you can see, the calcium is well distributed concentrically 360 degrees. And we did two or three runs with a 1.5 burr and stented with a 3.5 times 32 stent. Results quite good. As you can see, calcium still present. Calcium still present. As you can see, the stent is there. The stent is opposed, but certain areas are not, you could see it's not well opposed, but the MLA was about 6. So what we come to take home message from here is the angiography underestimates calcium. So severe calcium affects procedural success, where there's acute non-achieving luminal gain, multiple stents and long procedures. Chronic problems, we can identify restenosis due to poor stent expansion. Imaging is important for proper diagnosis and classification of severity, and OCT demonstrated effective debulking mechanism with the OAS device. Further reading you can have with this expert consensus document of the European Association of Percutaneous Cardiovascular Interventions. This gives you a good insight into the various coronary imaging techniques. Thank you.
Thank you very much, Bala. That was a nice series of cases. You've shown some difficult, heavily calcified vessels there that you've tackled. Now, can I just ask you a question? If you hadn't had the availability of OAS or, OCT or IVUS at your disposal, how would you estimate adequacy of atherectomy in such patients, in such vessels? I mean, before you proceed, decide to go on to the next several runs more, or is it adequate? Assuming just based on angiography, what are your tips and tricks that you would guide us in terms of adequacy to say that, well, yes, I've done enough. It's time maybe to use a non-compliant balloon or go straight to stenting. What are your pearls of wisdom in regards to this approach?
Now, looking at the angiographic films in various levels, I would still say that if you are not satisfied that the expansion is adequate, do not stent, please. You must achieve a better outcome long term. We don't look at short-term outcomes. Short-term outcomes, you can deploy a stent, well, fine. But the long-term outcomes are very important. So I have seen our common mistakes just accepting face value lesion which has not been expanded well. So at this stage, I would still use imaging. I would still would like to use imaging as a modality.
Right. Thank you. What about comments from other panelists? Tiong-Kiam Ong, you are also there. Prof. Koh-Han, on in regards to adequacy of atherectomy or vessel preparation before stenting. Say, in the absence of imaging devices such as OCT or IVUS. I mean, would you balloon with a non-compliant balloon of the stent size first and see whether it fully expands? Remember, these are calcified lesions that we are referring to. So how would you test for adequacy of vessel preparation before you stent? Kamaraj or anybody else who has comments on this?
Yeah, I think Bala. Go
ahead, Chee.
I think Bala has a very good point. I think imaging will definitely tell us who is our enemy and whether we actually give a perfect result. But the issue with us in our institution is, of course, it's a cost issue. We would love to have the imaging part just to tell us whether the vessel has been fully prepared. But I think in the setting where cost issue is an issue, then I think what Dato have mentioned just now, using a balloon to actually tell us how expansion is might be a good idea. What do you think, Kamaraj?
No, I agree with you, Chee. You see, the problem is we cannot do IVUS and OCT for all our cases. The balloon is the most important thing. So we have stopped completely doing this so-called direct stenting in Sedang. I've taught all my trainees, all my juniors, please make sure you use a standard balloon. You don't even have to go by the same size of the vessel. At least use a 2.5 NC and just see how it expands.
Okay. And
that is very important because, well, we have had to rota and stent 4 times already. So we don't want we don't want that kind of thing to keep on happening. So that's why we don't do any direct stenting. Everything is with after a pre-dilation.
This begs the question of this calcified lesion. The most overriding issue is unpredictability.
Yes.
How well does it open? How does it respond to rotablation or OAS? How well does it expand, and so on and so on. It's unpredictable. So we try and minimize and narrow that gap of unpredictability with calcified lesions. So that's why I wanted this opinion from all of your expert panel's opinions. Anyone else? You were saying, well, Kamaraj, you were about to say something.
No. Just basically that we need a pre-dilation before you try to stent. And if, as Dato Bala said, if you feel it's not opening properly and there's no way to get it to open properly, you just come back another time. You don't stent it, and create a bigger mess.
I think, Azhari, your point is well taken, because not every center has intravascular imaging. So for those centers who do a rotablation or atherectomy and they don't have intravascular imaging, then the balloon test, I call it the balloon test, is sometimes helpful. So that if you view in 2 different orthogonal views and you use let's say a non-compliant balloon where the nominal pressure is 12, but the balloon fully expands at 8 atmosphere in 2 views, I think the lesion is reasonably well prepared. Before even going to nominal, the balloon is fully expanded. I think that's a reasonable test. If you don't have intravascular imaging.
Right. Good point. Thank you very much. So with that, I think it's time for us to move on to the third speaker, which is presented by Dr. Kumara Gurupparan. He is a consultant cardiologist at National Heart Institute, and he will be talking to us about how to treat high-risk patients. Dr. Kumara, your screen.
Thank you very much, Dr. Sri. Can you all hear me?
Yes, we can hear you, no problem.
So, can the slides be seen?
Yeah, slides are okay. Good.
Okay.
We haven't got the full screen yet. That's fine. Yeah.
You see it? Okay. So thank you very much, Dr. Sri, and the wonderful panel, and of course OrbusNeich for having me today. So I've been asked to share a couple of cases on how we treat some of the higher risk patients. Can we go to the next slide? Just give me a minute, please. Yeah. Okay. So I think we have gone through some of the very important points. My personal opinion, never ever underestimate a calcified lesion. I think that's the biggest mistake any interventional cardiologist can make. They, like what Kamaraj said, it is probably a devil, yes, and never ever underestimate it. Treat it with utmost caution, and the case has to be really well planned before embarking on anything. Good vessel preparation is extremely important. I think Dr. Bala has also shown the role of imaging in making sure that we have actually cracked open the calcium and to ensure that the stent can actually be well deployed. If the vessel is not properly prepared, then we are definitely going to go in for some quite horrendous complications, and sometimes even end up with mortality. And there are various modalities available. We have gone through some of the atherectomy devices. There are so many scoring balloons, cutting balloons, and it is not necessary that one has to familiarize with everything. At least get to know one or two modalities and make sure these you're comfortable in using them. And as time goes by, technology has made it more easy to use. These devices are also widely available. And good vessel preparation and planning of a procedure actually extends the longevity of stents, and of course avoiding complications. And of course use imaging modalities when available, IVUS, OCT as much as possible, of course, if cost permits. So our experience with Diamondback at the National Heart Institute, we have been using it since January 2019. So far we have used it in about 90 patients to date. As we have seen from the previous presenters, the Diamondback system is relatively easy to use compared to the rotablation system that we have been using for the last 20 years. It comes with one single crown, 1.25 millimeters, and two speeds, your 80,000 RPM and your 120,000 RPM. So let me start with the first case. This was a 76-year-old teacher. He had long-standing diabetes, hypertension, mild renal impairment, active smoker, smoking about 20 cigarettes per day, was admitted to a district hospital with a non-STEMI cardiogenic shock, was ventilated, intubated, ventilated, and medically managed and discharged home. Had an echo, baseline ejection fraction of 45%. So was seen in clinic counsel for an angiogram, angioplasty, and he agreed. So this is his angiogram. I hope all of you can see. What you see here is actually the circumflex, a huge circumflex, a very dominant left system with a very tight lesion in the proximal segment at the proximal segment spreading the first OM, and then a very tight lesion in the mid segment and heavily calcified. The LED is mildly diseased, not much to, the left main is okay. This is another view of the circumflex. I mean, this is one of the few times I've actually seen such a big circumflex and actually going right down to the apex. So this has been a very important prognostic vessel for this patient. And the right system was very small. So if you can appreciate, this is what we are facing now. We have this is a better picture with a guiding catheter. We went in with a 7 French extra backup EBU 3.5 femoral access, and this was where the tightest lesion was, right at the OM1 bifurcation. Very tight segment and heavily calcified. It was a tortuous vessel, so and since it was single vessel disease, there was no option of talking about surgery. And since it was a non-STEMI and he had still some angina on exertion, we decided to offer him angioplasty. We expected this to be a challenging case, so went in with whatever necessary precautions. We had 2 wires, one cyan blue into the circumflex, run through flop into the OM1. This was a pre-dilatation with a 2012 Sapphire II NC, an excellent NC balloon. What we could do was we could only pre-dilate the proximal part of the disease segment a little bit over the bifurcation area. And when we tried to advance the balloon earlier, it just couldn't go down, and we were caught with a very tight lesion which refused to open even at high pressures. Well, there is a risk of doing this. If we create a dissection, then there'll be no chance of using any form of atherectomy, and using a balloon with high pressure in a very tight lesion, of course, predisposes the lesion to perforation. So we were prepared. We had all the necessary covered stents at arm's length. We really could use it if we really needed to. We then further pre-dilated the proximal part of the lesion with the Scoreflex NC 2.5/15. It opened quite well. So we were quite confident that this part of the vessel is well prepared and that we'll need more help opening up the tightest part. So we decided to proceed with the orbital atherectomy. And before we did that, the few things that were done. Number one, the wire into the OM branch was removed because the ostium was not diseased. So we were quite confident that we're not going to close that off. We exchanged the wire using a microcatheter. And then this is the wiper wire. As you can see, it's actually a nitinol based wire. And using the diamond bag, we went in a few runs at initially 80,000 RPM, and since it was a biggish vessel in the proximal part of the disease, at 120,000 RPM. So of course, we had expected some complications because this was a left dominant system. The patient was very dependent on the circumflex with a very small right. There's hardly any support from the right coronary artery. So there was some drop in blood pressure, some poor distal flow, but this was managed easily with just aspiration with thrombustor. Some adenosine was given through a thrombustor to improve distal flow, and a short episode of bradycardia which resolved with 0.5 milligrams of atropine. So we thought that after OAS, things should improve and that our deliverability of other devices should be fine. This was an IVUS. IVUS was done to assess the size of the vessel. And I couldn't share the IVUS images now, but it was a 2.535 vessel. So prepared the lesion further with pre-dilatation using a Scoreflex NC at 2.515 balloon. To our surprise, the Scoreflex, even at reasonably high pressure, refused to open at one particular point. And this was almost at 18-20 atmospheres. And that segment alone refused to open. So this is post-orbital atherectomy, and this was after 80,000 and 120,000 at RPM. And we then used an OPN, high pressure balloon, 2.515. This was 15 balloon, and we had gone up to almost 30 atmospheres. At this time, I was thinking whether we should go in again with an OAS, but that's going to lead to a lot of wire exchange and things like that. But there is no way we can proceed with stenting if this lesion did not open up. And finally, we thought, okay, what the heck, try with a shorter OPN so that there is more focused pressure on the lesion. So this was the 2.510 millimeter OPN, which at 34 atmospheres opened up, right? This is not something that you would want to try routinely, but this was done with utmost care with a covered stent nearby, because the risk of perforation is definitely higher with the use of such devices, right? But we were fortunate that finally the OPN, the shorter OPN, could deliver enough pressure to actually crack the calcified lesion best. After that, there was nothing much. The flow was good, and we could implant stents. Since this patient was a high bleeding risk patient, we decided to use a stent which was which had an indication for 1 month DAPT. So in this case, we had to implant 3 stents. The first one was a 2.533, 3.033, and then a final 3.528. It was actually a very long lesion. Then post-dilated with a 3.035 from 18 to almost 22 atmospheres. And these were the final results. I must say that we have achieved quite good results, and maintaining the patency of the OM branches with good distal flow. And as you can see, this is definitely a huge vessel, a prognostically important vessel for this patient. And I must say, in my experience, I've really not seen a circumflex this big, which is like going down to the apex, and this was almost like treating a dominant, an important LED. So the final shots. Total contrast is about 130 mils. We monitored his renal profile for a few days and then discharged third day of procedure. He was given 1 year DAPT, Brilinta and cardioprin, planned for 1 year of DAPT, just in case of any bleeding tendencies, then at least the DAPT can be shortened or safely taken off after 1 month. So he was seen again in 3 months. He was well, there's no more angina, good effort tolerance, managed to convince him to quit smoking, but that's something more difficult, to do than doing the angioplasty itself. So this is the second case, a 78-year-old lady, long-standing diabetes, hypertension, and dyslipidemia. She has been on regular hemodialysis for the last 4 years, now presenting with chest pain and intradialytic hypotension. So whenever she goes for dialysis, she cannot tolerate for more than an hour. It has been happening for the last few months, and she was not adequately dialyzed. A treatment option of doing CAPD was considered, but because of family situations and she being not having enough social support, it was deemed not suitable. So she was seen in our center. She was a frail lady. She was only 48 kilos, BMI of 22. Her ejection fraction was 25%. The registrar who saw her in clinic actually did a viability scan, and to our surprise, it showed that all segments were viable. So she's posted for a coronary angiogram, which showed this very diffuse disease. The LED is diffusely diseased. There's a tight lesion in the mid-left main, heavily calcified, and since it was all viable, there was something that we had to do. The right system was no better. There was really heavily calcified proximal to mid segment, a very tight lesion in this in the mid segment, distal segment, and as you can appreciate, it's actually a very dominant RCA. We stopped after the angiogram. We discussed with the patient and family. Very reluctantly offered her surgery, as we know that no surgeon is probably going to graft her. She's 78, frail, small size, on dialysis. And as expected, the surgery was declined as she was deemed too high risk. So we had discussed the option of complex angioplasty with atherectomy, and she and her family had agreed as she was symptomatic. So as you had appreciated earlier, there's heavy calcification from the left main into the LED and the proximal side of the RCA. The first PTCR, the rotablation, was done from the left main to LED. Not much of a drama. This was done with a 7 French guide. We managed to rotablate from the proximal right up to the mid segment. Just to cut the story short, we managed to put 2 stents, one 2.5, another 3.5, and then upsize 3.0 and 4.0 into the left main. Pretty decent results, I would say. We managed to preserve most of the septal and the diagonal branches. Tolerated the procedure quite well, so we decided, okay, now the LED is done, so we should proceed with the RCA after 3 days. This is a stage procedure. This is the procedure I wanted to actually share with you. The RCA was done 3 days later. It was a left femoral artery and vein puncture. Since the EF was low and relatively her heart rate was only about 50 or 60, TPM was inserted under fluoroscopy, and this is something that is advisable to be done whenever we attempt rotablation or any form of atherectomy, orbital atherectomy, to the right coronary artery or even a very dominant circ. So before we proceeded with the right, we decided to check on the left first, making sure that the stents were patent and that we had good support. Ejection fraction was about 25%, so we didn't want to take any chances. So we were quite happy that the left system was still fine. Proceeded with the right side. This is a 6 French short AL 0.75 guiding catheter, and wired down relatively easy. There was not much difficulty in getting the wire down. Opened up the distal lesion with a Scoreflex 2.0 NC, 15 millimeters. Why a Scoreflex? Because it's a scoring balloon. It gives you controlled dissection, And my intention was not to put not put too many long stents, but just to treat it with drug-coated balloon or drug-eluting balloon if there was not much dissection. And another important reason for opening up the distal segment is to ensure that there will be no slow flow if we are intending to do atherectomy in the proximal to mid segment. So angio check showed that not bad. The lesion was quite well prepared. The trick to it is going up very slowly with the scoring balloon at 2 atmospheres, then slowly to 4, 6, 8, and then to the nominal pressure of about 12 atmospheres. And then after about 20 seconds, you go down slowly to not allowing your nurse to press on the inflation device and deflate the balloon immediately. No, is to go down slowly from 12 atmospheres to gradually to 10, 8, 6, 4, and 2, and then deflate. By doing such gentle inflation and deflation, we can actually reduce the chance of getting dissections and allowing us to have more options of treating the lesion, either with a drug-coated balloon or even a stent if it's necessary. So in this situation, we were quite happy. There was good distal flow. The distal lesion had been prepared quite well. This would allow us to actually use a DEB. Now comes the part where we have to exchange the guide wire. The initial guide wire was a cyan blue. So I used a 3015 NC balloon. Why a 30 NC? Because I was quite sure that I was going to use a 30 stent, and I could use this 30 NC balloon to post-dilate the stent later. And then with a balloon inflated in the guiding catheter very close to the ostium, I would then slide a micro catheter. In this situation, I used the teleport and then deflate the trapping balloon once the wire is out of the microcatheter, advance the microcatheter right down to the distal edge of the vessel, remove the cyan blue, exchange it with the 014 wiper, and then remove the microcatheter. This is actually a very important step, and it's good to familiarize on the way that how we could use a balloon trap to actually exchange the wires. So then we proceeded with orbital atherectomy, and this is the diamond bag system. The vessel was not big enough for us to go into high RPM, so this was done with only 80,000 RPM. Very gentle, advancing the device slowly, making sure that we have adequate pitch that we achieve, knowing that we are really touching the calcium. And there were episodes of bradycardia, and she was dependent on the pacemaker for a short while. And once the orbital atherectomy was done, it was removed, and this pre-dilatation was done with a Scoreflex, a scoring balloon 2515 from the mid segment right up to the ostium. And before we advanced the stent, decided to treat the distal RCA with a short DEB, a 2.5 by 20 drug-eluting balloon, and then IVUS was done to size the mid and proximal RCA, because I was quite certain that it was it has to be a big vessel with such large distribution. So the first stent was a drug-eluting stent at 3034, which went in without much difficulty. I think the most important point here is the good guide support. We had a very good guide support with a short AL, 7 French, and with good vessel preparation. We did not have to use any other support to get the stent down. This was it went down quite smoothly, and then managed to put the second stent, which is a 3528, making sure that it was right at the ostium. So how do we do this with the SAL? It is a bit challenging, but with practice it becomes quite easy. So you gently disengage the guiding catheter, making sure that you don't pull out the whole system, and then the stent is deployed with the marker right at the ostium, and then a gentle puff of contrast to confirm placement, and then the stent is deployed. If there's too much rocking motion, then the stent can be deployed slowly at about 2 to 4 atmospheres, check with some puff of contrast, and then once you are very certain that the stent is exactly placed at the ostium, it is fully deflated and deployed. The rest is quite straightforward. And the whole 2 stents were post-dilated with a 3.0 and 3.5 non-compliant balloons, and some people do this, some don't. I routinely do this flaring of the ostium. This was done with a 3.5 millimeter balloon at 24 atmospheres. Just be careful not to dissect into the aorta, and make sure that your guiding catheter is free and not hitting onto the edge of the stent. A post PCI IVUS was done, which showed the stents were well expanded and well opposed. And these were the final results. Pretty decent, I would say, for a lady at that age of 78 on dialysis, frail, without much surgical options. So managed to get good flow to the distal RCA. This was the LAO view, and this is the epicranial. And then this was the RAO view. So groin shot taken shows that being a peripheral guy, looking out for anything else that we could help offer her, but she had a occluded left SFA, and that's not very surprising given the fact that she's really an arteriopath. So in this situation, she's definitely not suitable for device closure. So we used the fellow seal, which is a trademark of our hospital, meaning getting a fellow to press on it. So again, these are the take-home messages. Never underestimate a calcified lesion. They can really hit really bad at you, and necessary steps must be taken to properly prepare the vessel. I can't reiterate this more, but good vessel preparation is the most important part of tackling a calcified lesion. There are various modalities available. The atherectomy devices, you have the rota, the OAS now, excellent scoring balloons with very good crossing profiles, and cutting balloons too. And this definitely allows the longevity of the stents to be extended if you really prepare the vessel well and use imaging modalities. IVUS and OCT, they really help to make decisions and allow us to know whether the vessel has been adequately prepared prior to stent implantation. Thank you very much.
Thank you, Kumara. That was a very good delivery of a very challenging case. I think the earlier case was very difficult because that nodule of calcium seems to be a very stubborn lesion. Now, can I just ask you in regards to that very hard lesion? You've used the Scoreflex, but you know the rated burst is about 20, and you went around about 20-22. But I know it's bench tested to 26 atmospheres. But have you actually used the Scoreflex to 26 atmospheres, or even dare I say higher? But
okay.
But I mean,
we have gone up to 30 with the Scoreflex.
Yes. Okay, so this is where
slowly.
This is where we are.
Yes.
Comments, anybody from the panelists? I mean, you know, sometimes we may have sometimes I find that you need to use repeated patients and repeated cuts, then finally you'll give way rather than going suddenly and cause a perforation. You know, so that may be a good point that you raised earlier on.
Can I ask a question about the first case? Can I ask Kumara about the first case?
Right, good.
Yeah, because your first case, the very tight lesion in the circumflex, and you actually had pre-dilated with the NC balloon followed by a Scoreflex. Is that correct?
Yep.
Yeah. After that, you did the OAS. The OAS was after the dilatation.
Scoreflex did not open. Yeah. Small Scoreflex did not open.
But the NC balloon did open.
A little bit, very little.
So you are not worried about dissection? Or do you think that would be the cause of the slow flow after that?
I think the slow flow more distal embolization, more than dissection. It was because once we had done the aspiration and given some adenosine distally from the microcatheter, flow improved. And I must say we have experience. I mean, the OAS is a fantastic device, but I find that the more occurrence of distal embolization, especially in very heavily calcified lesions. So we are always prepared to aspirate and then give some adenosine and try to establish distal flow. In this situation, I was very, very sure that there was no dissection before actually putting in the OAS.
So may I ask the experience of the other panelists and the other speakers, your experience? Because personally, I have never dared to really do an OAS after a balloon dilatation. I would normally do the OAS first before I do any ballooning. And there's a fear of a dissection. I don't know, what is your experience? Have you managed to do it the other way around and got away with it? If it is, then maybe this is okay.
Comments, please, everyone.
I think the most important thing is to try to avoid dissection. And if let's say there's really minimal dissection, for example, then you got quite safe. But if let's say dissection is clearly seen, then this is something you want to avoid, because the crown can catch hold of the flap and you can actually have a spiral dissection. So that's the main reason why you want to avoid. But if let's say you're clear, then you can think about using OS. But otherwise, you got to be very careful.
In regards to this OPN usage, Kumara and the other panelists, there's always the fear of this kind of nodules actually causing perforation, and it has, I'm sure. The problem is, how do you minimize that risk in the use of OPNs in such lesions or calcification? I mean, is this a gamble kind of thing? You know,
you're bringing up a balloon at 40 atmosphere. I would think it's a gamble.
It's very much a gamble. I think when you are pushed against the wall and you're running out of options, it's something that you may want to consider, but with extreme caution.
I mean, you mean by keeping a covered stand nearby?
Stand next to you, yes. We will not use atherectomy device without covered stands in the cath lab. So we were prepared. Practically our heart stops whenever the OPN goes above 30 atmospheres. So we do it very gently, slowly going up, making sure that we hope for the best, but it's a bit of a gamble. I agree. But with more experience, I think it's a fantastic balloon, especially when there's a very heavily calcified lesion. You have tried atherectomy, your scorings have failed you. So, I mean, in times of need, the OPN really helps. I think that Rosli has shown us in the past, the OPN really helps in very heavily calcified lesions, especially. Yeah.
I think the practical basis is that to try to minimize the risk of dissection is perforation or balloon bursting. You need to go after a certain pressure, you need to go a bit slower. For example, with a normal non-compliant, after 20, you cannot go immediately to 26. The risk of conduct is going to be higher. So after 20, you want to go to 22, 24, a bit slower, 28, and even. And it's the same with the OPN and C balloon. The only problem is that the higher you go, the pressure, the balloon expands outwardly and also inwardly. So you find that it will grip onto the wire. So you've got to be very careful when you pull up the balloons.
Right. So that's a gradual escalation and de-escalation of pressure. That's a very important point you raised, so to reduce damage to the vessel. The other question that was listed on the published list answered by Rosli, but I also like to highlight one of the issues that was raised, which is the angulated lesion. And I think angulated lesions, the problem with calcium is that not only is the severity important, but also the positioning, the location, geographical location of these calcium plaques. You had in your circumflex, Kumara, an angulated lesion, and Rosli mentioned that angulated lesions have a risk of perforation, and I think it is especially so in the OAS because it tends to go to the side a little bit more circumferential. Is that right? Yeah. What are your comments on that? I mean, with regard to these angulated lesions and calcium located in the less ideal places at an angle, for example.
I think that's very true. The OAS tends to take the bend and shaves off more in any acute bends towards in any angulated lesions. So when we have a very challenging calcified lesion in such as the one in the circumflex, the first case, the OS has to be done very gently and not to rush and to ensure that you don't push it too much. It's with very gentle escalation. You try to shave it as much as possible. I think rotablation has got a similar issue also. But it's less risky, especially in angulated lesions. I think rota would be a better choice personally for angulated lesions, as you don't have a preferential or more shaving more on one side compared to the other, because it's more the shaving is concentrated more on the tip of the burr compared to the sides.
Right. And another important question that was raised is in regards to lesions that are long and the use of devices in long calcified lesions. There was also mentioned about difficulty in advancing some of the OAS. Rosli, you mentioned that sometimes it's difficult to actually get the OAS across such a long calcified lesion. And I think part of the reason is that whenever you push forward, and I've experienced that in the past, it just doesn't move forward as much as you like. You're not getting a one-to-one movement forward. what are your thoughts on this? Rosli, you've answered that question that was raised earlier on.
Yeah. In fact, I was, in my slides, I'll be showing one sort of an issue, same issue. The tactile feel and the sound is much better with the rotablator. So this tactile feel is something that you've got to acquire with OS. You don't really feel that much, but roughly you should know if you are intending to move 1 or 2 mm per second, and it should move 1 or 2 mm per second. And if you find that it doesn't move in a very severe calcified lesion, then you know that there's lots of resistance and you need to just back off and go in again. Because if you push in too much, and number one, it's concern of slow flow, and number two, sometimes it can suddenly jump forward. So if it jumps forward, that's when the risk of dissection or even perforation is higher. So the feel is something that you've got to acquire over time.
Right, point taken. So with that, I think it's time for us to move on to the next and final speaker, which is Dr. Rosli himself. These are in regards to many of the issues that's probably been addressed earlier. And this is tips and tricks in handling complex lesions. You've got some interesting cases, I believe, Rosli. So the screen's yours.
Yeah, so let me see. Is this one? Oh, yes, that's right. I wonder whether you can see the slides.
Yeah, I can.
All right, okay. So thank you very much for having me for this session, because OS is something extremely important, interesting. But I'll be covering a couple of cases, and probably not all. But the right coronary artery is one of the concerns that we always share, because the risk of a heart block, AV block, and the need of temporary pacemaker is much higher, especially with rota. We're going to just see a patient where we also look at how to treat osteolesions with effective atherectomy. Obviously, lamine is one of the things that we like to use OAS, and to see how we can perform confidently and safely. Then about diffuse long lesions with severe calcification, is OS the answer to all calcified lesions? And this is something that we have shared upon discussion, that it might not be the right answer to all. Maybe rotablator is going to be the way to go. And of course, in tortuous lesions, the need to avoid OS jump and the risk of dissection and aneurysm formation. So let me go through the first one, which is the right, and this is covering the ostium and a large dominant right in a 76-year-old man with a recent inferior MI when he first presented to us. So this is the case, the images. You can see severe calcification, the ostium to the mid-right, and the severe stenosis that is seen. But, usually we do a rotablator for this case, and there's a large dominant right. You're bound to use a temporary pacemaker, because it is bound to, you're bound to get AV blocks and SARS. But we find that as the need for TPM is much lower, because you go at lower speed, and higher speed causes more heat injury and therefore slow flow. And in fact, if you look at the orbital crown that has been shown, it does allow for flow, because it is centrifugal force, and when you it's not like a rotablator where it's just going forward, and this actually allows some flow to go down, and therefore the risk of slow flow, no flow is going to be much less. So this is a patient that we did. Sorry, you're competing with a thunderstorm at the back. So this in a tortuous iliac vessel, it is very important to get good support. Once again, this is a basic PCI. So in this case, we put in a long arrow sheath, and from there we can get the good guiding support. And this is very important to try to advance any devices in a calcified lesion. This is wire crossing. I think this is quite standard in trying to cross across the osteal lesion. Then we were able to put in a teleport microcatheter, and this was then exchanged with the Viper wire. Now I must say that the Viper wire has got very good support, and the body is rather stiff. So it's good in terms of support and getting any devices to cross the Viper wire. So this is done at low speed, and this is shortened, and you can see, look at the heart rate, and you can see that over time we can see that it becomes slow. So when it comes, you cannot be seeing the ECG at the same time because it's too much of a hassle. So you look at the images on your screen, and if there is a slow flow, then you should actually stop. And this is a patient that went to bradycardia, but the patient recovered, and what we need to give was we gave IV atropine and intracoronary nitroglycerin to treat whatever spasm. So essentially, if you look at calcified lesion, especially for the right, you must remember, recognize bradycardia and stop the OAS run. You should not proceed because otherwise you can run to more problems. And if you have this issue, then you should allow for longer resting time in between the runs. Essentially, you are allowing the vessel to breathe. And subsequently, when you go on for subsequent runs, it should be a short run. I've had patients that I've gone to just 5 seconds, stop, and then allowed to rest, and then go in again, and every 5 to 10 seconds. So very short runs. In this case, if let's say you have problems with bradycardia, you should avoid high speed and get ready with GTN to overcome any spasm. And of course, IV atropine is on standby. So in this case, we went on for low speed, and he had no problems subsequently. And once we have done that, and you can see the ECG shows no change over time. And once we have done that and we felt that it was quite all right, I decided to use high speed. And the reason for high speed is because it's a large vessel calcified lesion, and it's only at the point where it's the osteal lesion. So you need to once again observe for bradycardia and short runs. And this is a case at the point where the OAS is at the ostium. You disengage the catheter, and when you pull back, do not linger too long at a particular spot, because then the risk of cracking the calcium and causing aneurysm formation can be much higher. So high speed in cases like this, especially for the right, if there is no difficulties that you encounter at low speed, and if you feel that and you see that there's lots of calcification that requires further debulking, and the vessel, of course, has to be a large vessel of at least more than 3O, you should not be using low speed, high speed for a small vessel, because then the risk of perforation is higher. And obviously not for tortuous vessel. Now, he was discharged the following day, and he was discharged well, but he had another lesion which is in the left main stem, and this is a bifurcation lesion, severe calcification in the LED. There was also lesions in the circumflex and high OM. And this is another image. So we went on with low speed, and this time he had no problems, and we went down until the mid segment. And we decided to use a high speed from diagonal 3 to the proximal, but because once again the vessel is big and we're dealing with left main, and we're trying to hope that to debulk as much calcium and plaque modification at the same time. So only at a point where the vessel was larger. Then this is the post-OAS. So over here is where we treated, and we wanted to treat right until the ostium. We prepared the vessel better, and we used a Scoreflex NC 2.5, went up to about 14 atmospheres. And this was the results after. So it looks quite pleasing, and you can see that there's no dissection at the point where the OAS and Scoreflex balloon is. In the proximal segment, we treated with a bigger balloon, and this time a 3.0 NC that we went up to about 18 to 20 atmospheres, and it was quite well expanded, so we decided to not go much higher than that. And that's the results after. And this is something that we tend to see more often with atherectomy, especially with OAS. You find that the results are quite good. And in these cases, we then said, we are going to try to use DCB, and we used 2 DCB in the mid until the point where diagonal 2 is with a 2.5 mm balloon, and subsequent proximal to that is with a 3.0 DCB balloon. So the other lesions were treated and stented, especially the left main, and I just want to show you the final results in this case, which was quite pleasing, and at least the patient did not have any problems with this procedure. So stents from here, but DCB from here until the mid segment. So once again, if you're to look at the with the left main stem tips and tricks, I would say that you start with low speed. Obviously, you shouldn't think of any lesions that you want to start with high speed. You should start with low speed first. And then if you want to go high speed is when you have no issues or problems during low speed and when you feel that more debulking is required. Generally, you need shorter runs in the left main and you don't want to lead on to slow flow and obviously, with the bradycardia. So in the left main stem, that's a no-no. And with atherectomy in OAS especially, we find that there's potential to allow DCB consideration to be used in a number of cases to try to avoid long stents. There's another patient that this was done in Ipoh, and this was done by Dr. Nur Hanim, and a patient who had non-STEMI and was brought over for OAS in a workshop. This just to show the calcification that is seen in the proximal LED, and you can see that it's quite coming off at a bend, especially at the mid segment where it gave rise to a diagonal 2. So the wiring was quite challenging. We kept going into diagonal 2, but in the end, with microcatheter, we managed to have a bigger band of the wire and went down into the distal LED. So just to show you how, I hope you can see this. This is a wire, a regular wire, and there is a microcatheter distally, and you can see the bend here. So that's where the tortuous or tortuosity was. And when you put in Viper wire, despite the fact that it's smaller, it's less than 0.14, but you can see that the support actually straightens the wire out. This is the, being very careful, Dr. Hanim being very gentle and careful, but still you can see that there's a small jump forwards. But this is where the control must come, because if you if you put the pressure too much and it goes forward, then it will go much lower than this. So that's a jump forward with when we go anti-grade. And when we pull back the device at the point where the tortuosity is, there you can see a short jump. And as we pull back, the jump became a bit more obvious. But I think it's still acceptable. So you just go in again and back, and hopefully you will get a much better plaque modification with this. So with tortuous lesion, you want to avoid excessive movement of OAS because of the risk of dissection and perforation. You need to anticipate the sites where you may have a jump, and you try as much as you can to control the jump. Sometimes you can't help it, of course, and I've had patients that, I try to control, but it still jump. But at least you want to try to minimize that jump. Obviously, the guide catheter must be well engaged. It needs to give good support to try to prevent this jump. You need to have a wire position to give you much better support, so the wire has got to be as distal as you can. And this is when we discussed just now the tactile feel, that when you push in, you should expect the amount of pushing in to be the same as when you see angiographically. So try to avoid too much force, because sometimes with this, too much force, you cannot control the jump. So this is after the post-OAS. Sometimes you see that after post-OAS, not much of debulking is being seen, but rest assured, if you've done a proper atherectomy, if you go, put in an IVUS, you will see that the calcium actually cracked, and you are now able to expand the lesion better and then put in a stent. So 3.25 post-dilatation was seen, and you can see that the balloon is quite full. There is no wasting. And with that, we are quite confident of being able to put in a stent. And this was discussed just now by Bala. Never put in a stent if there's significant waste in the lesion, because the stent will not get expanded. It's more difficult to treat when you want to try to expand the stent in a calcified lesion that has not given way, unless, of course, you have the lithotripsy balloon. This is a combo plus that was deployed full. And when we went with a post-dilatation with a 3.75, once again, it's full. And this, you can see the results. So very nice, results, well expanded. And you can see that the D2 is preserved. Okay, so I've got one last. I don't know whether I've still got time, Azhari, to just show you, because I think this is very interesting. It's something that we should consider, because I really wanted to show this, though Jenny was a bit concerned about it, about aneurysmal formation and post-OAS. And this is a patient that you can see it's calcified in the LED, and you can see the distal left main is severely stenosed LED, and the LED is a CTO in the mid segment, and there's also a stenosis in the there you can see that in the proximal ostial circumflex. I know, TK, you would say, why did you not send this patient for surgery? But this patient was referred to me because he refused surgery and the LED was diffusely diseased. So what we did was we OAS the left main stem first, and again slow. The strategy was really to PCI the left main stem LED and into the D1 and circumflex, and we wanted to have a stage CTO to the LED. So OAS the left main stem first, and this was the results after post OAS left main. Results was at least you improve flow in the LED and diagonal. We then did the OAS into the diagonal branch. So the diagonal was seemed to be at least 2.5. So we say we can try to do OAS in this case, OAS into LED diagonal. And this was the post OAS in the LED in diagonal. And subsequently, we went on to cross into the circumflex. You can use a glide assist. I think it will be much easier, but I wanted to test this device. This was only the seventh patient that we did. So this is pushing without glide assist. So we were able to cross the lesion, what seemed to be a tight lesion. So it's quite good. So it tells you the good thing about the Viper wire. Very good support. Now this is then, we then did the, let me see whether there's any moving image. Yes. So I did an OS atherectomy from distal to proximal. So have a look at this and see what I did. And, I slowly pull it back, not much of resistance. The guide did not go in, so not much of resistance due from the stenosis. So as I pull back and then I went forward again. So what I wanted to do was, I said since the circumflex is large, is a left main stem, I want to, dwell a bit longer so that I can debulk as much, even a slow run. And this is something that you will see that we should not do. So this is the results after, and you can see that there is a dissection here at the ostial circumflex. And this is probably because of the crack in the spot of the calcium. And the reason for this is the fact that I lingered a bit too long. And secondly is because of the wire biasness of Viper. So the Viper wire is a good support wire, but because of its stiffness, it has caused wire biasness, and therefore differential cutting was not seen in this patient. So it cut more at one side. So we then went on to dilate, the diagonal LED and also the circumflex lesion, and this was the results. And you can see that the amount of this so-called aneurysm formation is now getting a bit more prominent. This is post-POBA. So I just want to give you this run, and you can see calcification from circumflex to proximal. There you can see the cracking of the calcium from the OS and the balloon. And as you go forward, look at the 2 o'clock region, 12 to 2 o'clock, there it is. And this is where the aneurysm is, the space is. Okay, so it cracked the calcium, cut open one, and then cut at one side of the vessel. And that's when we go into the LED. This is the LED wire. All right, so that's what it looked like. So anyway, so this is the results before we treated definitively. So we used a DCB in the D1, and in the circumflex we put in a stent. And we've ended with final kissing, left main stem to the second LED. The LED is just to open the stent struts to allow us for stage PCI subsequently. And that was the final results. So once again, I will give you an OS picture in a post-stenting. And as you can see, that's a stent. Remember the point where it came out at about 2 o'clock, and that's where the aneurysm starts. So that's a stent, and that's where the aneurysm is. Of course, it will is going to float inside the aneurysm, but you can't be trying to meet the aneurysm, and you want to try to avoid more injury to the aneurysmal segment. So that's where the LED is. The patient was brought back for a stage PCI to the right, rather to the LED. But 3 weeks later, you can see that aneurysm is a bit more prominent, but the flow in the LED and the circumflex was good. We then ended with rotablator, so this had to be rotablated. We couldn't cross the OS, and it was very difficult. We had 10 runs before the 1.25 burr crossed, and then we ended with 2DS in LED with the tap technique, and that was the results after. So when you look at what happened in the aneurysm formation, there's a fractured calcification, and it happened lesion at the bend. In this case, I think if you have a lesion at the bend, it is more ideal to actually do from distal to proximal rather than proximal to distal. And with this, once you cross and when you pull back, you have better control than when you just push forward, because sometimes when you push forward, you don't know whether the lesion is going to give way and whether you're going to have a jump in your device. But once you go more distal, you know that it will not jump because your device has already crossed the lesion. Remember not to linger in any particular spot for too long. And obviously, you do not go for high rotational speed. And in this case, it's due to wire biasness. And this is due to the stiff support Viper wire. And I think that this should be overcome with the new nitinol wire that is softer, at least in the body. So that hopefully can prevent aneurysm formation. So in conclusion, ladies and gentlemen, so I think I'll just go to a number of things. It does take a bit longer time to complete long lesions with OS, but I find that it is safer with less complication, especially with slow flow, in particular the right. And nowadays, I do not put a temporary pacemaker for the right. There is still a steeper learning curve, and we said that the tactile field and audio recognition is less than with rotablator. You got to be very careful with heart failure and poor LV function, and especially and CKD with poor urine output, as has been answered by Dr. Chee just now. And I did discuss some of the issues with complex lesions. We did not have time to actually discuss one patient when you can't do OS, but if you can't progress with OS in long lesions, severe stenosis and calcified lesion, then you must know that you must change over to a rotablator as soon as possible, because if you have problems with slow flow and if the LV function is poor, then the patient may actually deteriorate and in that instance. So you must actually know when, if your OS doesn't progress, you must know when you need to convert to a rotablator as soon as you can, so that you are able to be safe and to do it more successfully. So thank you very much, ladies and gentlemen.
Thank you very much. That was a very important learning point, and you highlighted the issues in regards to the choice of lesion for OS. Now, I have a question. You mentioned about audio recognition. Can I just highlight a situation whereby you have a long calcified lesion that you're going to OS. Now you have a choice between angiographically it looks okay, but audio-wise there's still that screeching sound, which means there's a fair amount of calcium whenever you do the pass, when you pass the burr in and across the lesion. So there are some operators who say, okay, you should pass it until the sound is minimal in terms of this high-pitched sound that you say, which means that there is very minimal calcium. Or would you just say, looking angiographically, it looks okay enough for you to actually proceed with further device or stenting? So what would you say is, this aside from imaging, what would you say is the best indicator of amount of calcium reduced? Would you say it's a sound recognition, audio recognition, or would you angiographic results? What would be a rough guide, for example?
Okay, let's go through with rotablator first, because that's where you can hear the sound and feel well. So essentially, when you have rotablator and you've rotablate well and you want to do a finishing polishing run, essentially it means to say that there is no resistance, as you say, the sound, the pitch doesn't reduce, so the RPM doesn't reduce, and there's no resistance, quite smooth. And therefore you say it's enough, the ablation for that amount of device. And we are trying to save costs and go for plaque modification. So in cases like that, you may want to decide to use a balloon. And if you use a balloon, you got to, 1:1 non-compliant balloon and try to crack it up. Right. If it doesn't crack up, then you may have to consider either using even a second device for rotablator. The other thing is sometimes you may even consider using 2 burrs from the very beginning. For example, so severe long lesion, so you have to use a 1.25 burr, and you know that there's still debulking. Therefore, then you use a bigger burr, a second bigger burr. Now, coming to OAS, you must remember the low speed sound allows you to differentiate whether there's still calcification, because there's there's 2 or 3 sounds you can hear. So the sound that you hear is a grinding sound. So that grinding sound is calcification. So if you still get a grinding sound, you still have some resistance as go more in and out, then you know that there's still a bit more work to be done. Now, when you go for high speed, you lose that grinding sound. It's very difficult for you because it's high pitched sound. And then when you have a wire biasness, it's a very shrill sound. So when it's very shrill, you know it's wire biasness. Yeah. So that's the difficult part when you go for high speed. And essentially, if you go for high speed, you just want to debulk, the aim of debulking more, but you just make sure that as you go forward, it goes forward and it goes back as according to what you feel. And the fact that it goes 2 or 3 mm, then it should go as 2 or 3 mm.
Right. Thank you, Rosli. And you mentioned about the size of the vessel earlier on, and there was also a question on the question section about the minimum size of your vessel. What is the minimum size? I think somebody said Chee said 2.75, but the record on the Orbit 2 is 2.5. Yeah. Would you dare to use it on a lower size? I know this is an issue, but what is your experience or comments on that? Or it's a definite no-no?
Well, the diagonal, if you look at it, it was like the last case I did. Some arguably would say that it's less than 2.5. So I really wanted to OS this and said it's a 2.5 usually. So it's actually, a 2.5 is safe. Shouldn't go lower than that, but I was sure that the diagonal was bigger. It's a sizable lesion, and therefore I use the 2.5, the OS, but not at high speed. It has to go on low speed. So
that's an important point. The key point about high speed and vessel size compatibility. Comments from the panelists in regards to the cases that we've discussed so far.
No, as Dr. Rosli said just now, I agree with him. You actually know how much of calcium is there only when you use the low speed. Yeah. So a lot of times what I do is I do a few runs on the low speed, and I find if I still have not debulked enough calcium, I go a few runs on high speed. But after that, I go back to low speed before I get out, so that I know from the sounds whether we have removed enough calcium. So that's the point. That's a good point.
So question also, how do we control a jump when using OAS? This is much talked about, this jump of the OAS. How do you minimize it? Rosli or anybody else, Kumara, comment on jump. Bala, is Bala still there? Comment on the jumping of the OAS in certain types of lesions.
Kumara?
I think it's almost impossible, isn't it? Because I find that with the OAS you don't push, unlike the rota, you don't advance. You actually just, you move, you don't advance. I don't know how to explain. You actually don't move, and then it seems to move so slowly, and seems nothing's to happen, and then you just jump. Yep. It's almost impossible. I don't know. I'm not sure whether other people have other tricks or not. Yeah, but I think the thing is not to move too much. Move as little as possible. Then the jump, it will still jump, but the jump will be very minimal. It's
more controlled, yeah.
Or you use it backwards from distal to proximal as well.
Yeah, that's another way.
Yeah. So, any other comments or tips and tricks anybody would like to share in regards to our OAS in these lesions?
The other thing is about aneurysmal vessels. As Dr. Rosli said, we also learned that basically you just glide through that area. Do not hang around there too much because it's a thinned out vessel. And the more you shave at that time, the higher chance you're going to develop the things like the dissection or perf. So just go forward and backward around that area, but do not dwell on that area for too long.
I think that's an important point, Kumara. And I think if you have this, especially true of very long lesions, in which you've done work on the proximal segment, and then you're trying to tackle the distal segment. So you don't want to switch on that burr and then at 80 and move along the same length down to that lesion where that's the area needs to be done. So you can glide assist up to the point which is the new area now, further down the lesion, then turn on the 80,000 RPMs, whatever. But I think if you start, the temptation is actually to start from the lesion source, start of the lesion as you did earlier on, and then burr down towards that lesion. So I suppose you glide assist areas that you've already done work on, and then concentrate to the burring on the more hard lesion, then that would be a better approach, I think. Use more glide assist, in other words. Is that correct?
Yeah.
There's also a question earlier on about the Rosli. I have a $6 million question for you, Rosli. This question relates to now that you've made available the OAS and the rotablator, would you say your transition, what is your conversion rate of rotor lesions to OAS? Would you preferentially use now that you have this safer option for OAS?
Well, again, it's not for all lesions, I think, so if I have a very long calcified lesion, then the chance of me pulling up a rotablator is much higher, because sometimes you spend a bit too much for OAS. But if I find that it's a large vessel, there's lots of calcification, then my choice is wanting to put OAS, because the chance that the bulking is a bit better, and plaque modification I feel should be better. So large vessel, large extensive calcification, OAS.
All right, thank you very much. Can
I ask one last question that will address all this because we seem to dwell a lot on OAS. Can I just ask one question, which I think any of the speakers can answer, which is that now we are talking about calcified lesions. When you have a vessel that's calcified, there seems to be three ways we can treat: a scoring balloon, a rota, or OAS. So how do we decide? I mean, do we need to always do imaging? And if only imaging can tell us which way it is best to treat this lesion, what are the features in the imaging, in the intravascular imaging, that tell us which modality to use? Who would like to? I mean, is Bala still there?
Yeah. Okay. Anyone?
All right. Okay. For me, of course you can, because you don't image routinely. I don't image routinely anyway. So if I see calcification is not that bad, then I'll try to use balloon. And sometimes it can give an idea, because if your balloon has difficulty in crossing, and if you have resistance, then you know that the calcification is a lot. In cases like that, then proceed to atherectomy. But if cost is a concern, and cost is an important issue, then I will try to use balloon and see whether I can get away. But if I see a lot of calcification from the very go, then atherectomy for me. Safer.
So Bala, you are here. The question is, if you do intravascular imaging, what are the calcification features that would tell the operator, okay, I can get away with just a scoring balloon, or I must do a rota? And if I do a rota, what are the features that tell you this one should do this one should do a rota, or that one should do an OAS atherectomy?
Actually, I agree with this now. I would prefer to just open up with a balloon, a scoring balloon, and see how the balloon performs. And that is to save cost. But if it doesn't open well, I would do a OCT to look at the lesions. If the calcium is very circumferential, more than 3 segments, deep calcium, I would go for OAS and not rota. Rota may be more superficial and less. And longer lesions, also I would take an OAS.
Thank you, Bala. Anybody else? Comments, please. I think we've come up almost to the end of time. If there no, does anyone have any final comments, final take-home messages? Maybe I can just finish up by saying that I think what we've learned is that we've known for a long time that calcium is challenging, but I think it begs us to actually appreciate that calcium's presence is not only the distribution, but also the pattern as well as the geographical location that's important, which enables us to decide on which best device to use for our patients. But I think increasingly the availability of the devices has opened up the choices for us. And hopefully in the near future, lithotripsy will be available, although I think cost is going to be prohibitive. I think some of us have been to Singapore to look at the device. But you never know. But I think the teaching lessons will not end here. I think many of us will have more and more experiences in regards to how best to use which lesion. But we welcome the availability of the OAS now, and we hope that many of our colleagues will be able to use this device because I think it works for better results at the end of the day. And the particles are so small, less than 2 microns, less than the size of RBC. The no reflow or less reflow is much less compared to rotablation. I think with that, I'd like to first thank OrbusNeich for giving us this opportunity to have this webinar. And of course, all of you for participating, and of course, such wonderful cases that we've had this afternoon, Rosli, Kumara, Bala, and the moderators, Chee, and Tiong-Kiam Ong. And of course, we'd like Kamaraj for that wonderful, difficult case, Kamaraj. So I hope that in the near future we can share more of these sessions. So once again, to the participants and those who have logged in, I hope that you've answered many of your questions that you have forwarded. And with that, I'd like to thank all of you for being with us for this afternoon's webinar. Thank you very much.
Thank you.
Yep. Thank you very much.